So thank you so much, everyone, for coming tonight. It's wonderful to see everybody here. And my name's Susan Hurahan. I'm one of the lead OTs here at the National Hospital. I'm really delighted to be introducing Dr. Diane Playford to you all tonight. Most of you in the room will know her. But we go back a little way, don't we? A little way. Diane won't know this, but about 30 years ago I was working at the Whittington Hospital, and Diane used to come across from Queen Square to assess the patients for the NIU. And I remember meeting Diane there, and I used to cover neuro outliers and some strokes. And just in those few moments that you were over there learning so much from Diane. And actually, she became my hero at that time. So it was after that that I came across to Queen Square and worked here since 2001. And we worked sort of not completely closely, because I'm not on the rehab side of things, until we set up the VOC rehab service together. And you'll all know that service and how successful it is. But Diane was instrumental in that, and in so many other things as well. And it's such a pleasure to have you here, Diane. Some of you will know Diane is actually an honorary fellow of the College of OTs. And the reason for that is that she's done so much to advance OT research and practice over the last 30 years, probably longer. She's put lots of OTs through PhDs and assisted with MScs, including mine. And she's just done so much for OT. And she's actually really wearing green trousers underneath those. Anyway, I'm going to hand over to her. No further ado, hand over to Diane. Thanks very much.
So, Susan, thank you. That was very kind. And I would say the VOC rehab service would never have happened had you not written the business case. So for that, I am eternally grateful. It's always a pleasure to be in Queen Square, and particularly at the Centre for Neuro Rehab. And tonight there is going to be no science. Some people think the Centre for Neuro Rehab is about science, but tonight there will be no science. So what I want to do today is to think about some ethical dilemmas, and particularly to highlight what I think might be a problem, which is the relationship between capacity and autonomy. So I'm going to start with a brief introduction to ethics, or at least I will do if I can get my slides to work. There we go. I'm then going to think a little bit about the legal frameworks and associated guidance, going to go from there to the 4 principles of clinical ethics, and then think about capacity and autonomy. So, a brief introduction to ethics. I am fortunate, I think that's the word, to have a son who is a senior lecturer in philosophy. And he's kinder to me than A.C. Grayling would be, because he tells me I paddle in the shallow end of the philosophy pool. And then he perhaps suggests that I should get out. We have written a paper together, by which I mean Richard and Tom put in the intellectual effort and I produced a few case histories. And in that we looked at the difference between deontological and utilitarian ethics in patients with PDOC, and highlighted that with different ethical theories you come up with different answers to some of the common problems that we see in patients in a disorder of consciousness. So I think it's quite useful just to start with a very brief overview of some of the main streams of ethical theory. So, utilitarian ethics is a consequentialist theory. It's concerned with the outcome of our actions in determining morality. The right action is the one that will result in the greatest good for the greatest number. And traditionally, that which is good is that which promotes happiness, however you define that. Act utilitarianism is only interested in the greatest happiness for the greatest number. So an example in medicine is the use of the cost per QALY to determine access to a treatment. Rule utilitarianism suggests we should obey rules that promote the greatest happiness for the greatest number. So an example of that is that competent people can make their own choices. Deontology, on the other hand, comes from the word of deon, which means duties, and it believes that certain actions are right or wrong in themselves and thus morally unacceptable, independent of the result. So, for example, if you believe that telling the truth is something that you should do, and you're sitting at home, and your next door neighbour comes knocking on the door saying, she's going to kill me, hide me, you can hide him, that's no problem. When his wife appears brandishing a knife saying, where is he? Have you got him? Instead of saying, I've no idea what you're talking about, you say, yeah, I let him in a minute ago, because that's the truth. And so it is the action that is right or wrong in itself. Virtue ethics focuses on the development of good character traits to lead a meaningful life. So there would be a series of virtues, and you might pick some like honesty. And if you think that you want to practice an honest life, you would not only not tell lies, you would associate only with people who told the truth and not those you knew who were liars. You would encourage your children to tell the truth, and you wouldn't find jokes about someone cheating on their partner or evading their tax amusing, because that's not honest. You would practice this virtue of honesty with some practical wisdom. So you would try and be discreet, and you wouldn't force information on people if they didn't want it. And if you practice enough of a virtuous life, then you can achieve a flourishing life or a state of eudaimonia. Feminist ethics came more recently to the fore, and the account of this says that feminist ethics aims to understand, criticise and correct the binary view of gender, the privilege historically available to men, and the ways in which views about gender maintain oppressive social orders or practices that harm others. From our point of view, one of the things that's important in feminist ethics is the concept of relational autonomy, which suggests that individuals are not isolated agents, but are shaped by their relationships and their ethical and their social contexts. And actually what's interesting is probably the more social contacts you have, the more autonomy you develop. In childhood, we have key relationships with two other adults, and we are not autonomous. As you move into your teenage years, your peer group become more important, you find partners, you go to work, you see different ways of doing things, and with each of those you become more autonomous. So although we might think that some relationships decrease autonomy, for example in coercive control, there are in many cases our relationships increase our autonomy. Now you can see that with all these different ethical theories there is a problem because they aren't mutually compatible. And so out of that, we end up with the 4 pillars of medical ethics. So the oldest of these is non-maleficence, first do no harm, and the newest is autonomy. And we need to think about these when we think about the associated legal frameworks and the associated guidance that drive the way that we work. So, when I think about what has happened in my lifetime as a doctor, things have changed. That is a ward at Bart's in the late 1970s, early 1980s. There are a number of things that are different from wards today. The first one is the nurses wore caps, the doctors wore white coats, the wards smelt of carbolic, and most importantly, the patients lay in their beds and did what they were told. And life was simple. Actually, it wasn't, but that's another story. So, what's changed since that time is not only an enormous shift in technology, but an enormous shift in social attitudes. And we would expect now to be less hierarchical in the way we operate, we would expect to be challenged in our decisions, and we would expect patients to question the information we are giving them. But that is a change that has happened in the last 30 to 40 years. When I qualified in rehabilitation, we were thinking about the traditional ICIDH model, in which we talked about pathology, impairment, disability, and handicap. There were still conversations about medical models of disability, where doctors wanted to fix people, and social models of disability, where disability was simply a social construct. And we've moved on from that position so that we now think about biopsychosocial models, and we recognise that the relationship between impairment, activities, and participation is moderated by personal and environmental factors. And the environmental factors include not just physical barriers, but legal, social, and familial, either barriers or facilitators. The personal factors include beliefs, values, and identity. And it is in these factors, these moderating factors, that I think many of our ethical dilemmas arise. In 1948, after the horrors of the Second World War, the United Nations came together and wrote the Universal Declaration of Human Rights. That was built on in 1966 with the International Covenant on Economic, Social and Cultural Rights, in which the right to health was laid out. So that is a piece of legislation, a guidance from the last century, which has been immensely influential when we think about the rights of patients. All doctors are aware of the Hippocratic Oath, and what is interesting about the Hippocratic Oath is that there are parts of it that are still relevant. Medical confidentiality, relationships with patients, and first, do no harm. We absolutely still understand those as key concepts. There are other concepts within the Hippocratic Oath which are of changing relevance, for instance, the views on abortion, or possibly the views on assisted dying. They're changing. And there are some which we might think are not relevant, some of the views described about surgery. And what that shows is that ethical frameworks change. And if you look at the modern equivalent of the Hippocratic Oath, this is the Declaration of Geneva from the World Medical Association. And this again was written in 1948, at the same time as the Universal Declaration on Human Rights. It's been amended in the 60s, again in 1994, 2005 and 2006, but it wasn't until 2017 that I will respect the autonomy and dignity of my patient was put into it. So many of these ideas are relatively new. And really, over the last 20 years, we have seen an explosion in guidance. The one that has made the most impact on all our work is the Mental Capacity Act. And that brought in ideas not only of capacity, but of deprivation of liberty safeguarding, of best interest decision making, and informed the way we think about consent. In 2006, the United Nations Convention on the Rights of Persons with Disabilities was set up, and really all that does is endorse that people with disability have the same rights as the rest of the population. It says you're entitled to the same rights as those in the United Nations Declaration of Human Rights. And there has been guidance on a wide range of ethical issues, and I did have a couple of slides which listed them, and then I decided there are so many that it was just a rabbit hole to go down. But the ones I would particularly highlight are clinically assisted nutrition, hydration, and end-of-life care. So the Mental Capacity Act has 5 key principles, and they will be familiar to everybody in this room. The presumption of capacity, individuals being supported to make their own decisions, individuals having the right to make unwise decisions, for individuals who lack capacity, best interests, and best interests being unrestrictive. or least restrictive. There is something called the two-stage functional test of capacity. And what is interesting is what you have to do is reverse the order of things in the act, where they talk about a disorder of mind and brain first. And you have to ask 3 questions. And the 3 questions are, is the person able to make a decision? The second question is, if they cannot, is there an impairment of brain or mind that explains that? And is the person's inability to make the decision because of the impairment of brain and mind? And it's important to do it in that order, because if you don't, you say, oh, well, they've had a severe depression, of course they lack capacity. And that's not the right way to do it. Now, principle 3 is the fact that a person is not to be treated as unable to make a decision merely because he makes an unwise decision. But in the Code of Practice, there are 2 other statements. There may be cause for concern if someone repeatedly makes unwise decisions that put them at significant risk of harm or exploitation, or they make a particular unwise decision that is obviously irrational or out of character. So let's just hold that thought for a minute and come back to the 4 principles of medical ethics. So, Ronan Gillen was a clinical ethicist who was very well respected, and an issue of the Journal of Medical Ethics was dedicated to him. And he made these 2 observations in an editorial. The reason that we need 4 of these 4 pillars of medical ethics is because the approach is argued to be compatible with a wide range of moral theories that are often in themselves mutually incompatible. So, if you like, the 4 principles of medical ethics are the area of compromise. And he then says, reasons are given for regarding the principle of respect for autonomy as first among equals, not least because it is a necessary component of aspects of the other 3. So when we think about the 4 principles, we have non-maleficence, and in practical terms, it's to obligate us to refrain from causing harm to others, and this can be intentional or unintentional. Probably the most common unintentional one is a drug error. In professional terms, what we're really talking about is a duty of care. And if you look at the GMC guidance at the time I qualified, it says they weren't interested in treatment decisions, but they were interested in neglect of duty. So you could treat a patient wrongly so long as you didn't neglect your obligations to go and see them and make a diagnosis and do everything else. Beneficence, we can divide into what is now called parentalism rather than paternalism, covers a range of things. And at the one end, you've got hard parentalism, where the doctor does what they think is right, whether or not the patient wants it. And that is morally indefensible. Soft parentalism is this grey area where we do something because we think it is in the patient's best interests. And then at the far end, we have consumerism. And in consumerism, you give the patient a choice, you give them the facts, and then you leave them to make a decision. And that is a long way away from shared decision-making. And I think in some respects, if you look at what happens now when we do consent for procedures, there is an element of consumerism in that, because we have a discussion about whether or not one should do the procedure or what the alternatives are. And only once it's been agreed you should do the procedure, do you then get a consent form which says you have a 10% risk of infection, a 1 in 100 chance of paralysis, a 1 in 1,000 chance of sudden death. Sign here. So that bit is really quite transactional and probably at the consumerist end of the spectrum. Justice is about how you distribute things. There are different ways of thinking about things, but probably what we normally do is around according to need or around an equal share. But it is different countries will have different approaches to this because there is a demand for health and social care that will never fully be met. And so we have to have some way of distributing what is available within the market. And last of all, because it's the most recent principle, is autonomy. And put most simply, to be autonomous is to govern oneself, to be directed by considerations, desires, conditions, characteristics that are not simply imposed externally upon one, but a part of what can somehow be considered to be one's authentic self. So each principle is not exclusive. They can be combined in their application, but it can be easy to see the difficulty in choosing and balancing these different principles when you apply them to particular problems. So what I want to do now, because we've heard the word autonomy and we've heard the word capacity, is to think about the relationship between capacity and autonomy. So, in law, there are three versions of capacity. The first one is that capacity equates to being a gatekeeper to autonomy. They are synonymous in practical terms. The second one is that capacity is necessary for autonomy, but it's insufficient by itself. It also needs freedom from undue external influence. And the third one is that autonomy can survive in capacity in the context of best interest decisions, in the context of things like advance directives to refuse treatments. Now, that leaves, if you look at that, those definitions, it leaves at least two classes of people who have mental capacity but might be thought not to have capacity, to have autonomy. The first are those who can't decide within the act, not because of their impairment, but because of undue influence by someone else. And the second are those who can decide by the criteria in the act, but nonetheless can't reach a free decision. Yeah? So they're just slightly different perceptions of the same thing. And I've said autonomy can survive in capacity in the context of best interest decisions, but the three factors that perhaps address that relationship are, for the patients who are still conscious and aware, are we respecting their wishes even if they're not capacitous decisions? And if someone knows their wishes aren't being respected, that can be distressing. So the possible impact on P of knowledge that her wishes and feelings are not being given effect to. Intelligibility, the extent to which the patient's wishes and feelings are or are not rational, sensible, responsible and pragmatically capable of sensible implementation in particular circumstances. So, for example, you may have a patient who is a devout Catholic, who was anti-abortion, whose family believed that they would want to continue whatever happens, but who is in a vegetative state. And if that vegetative state is associated with paroxysmal sympathetic activity, and the patient is storming and they're spasming, and if they've got gastric stasis and they vomit and they're getting repeated chest infections, and you then decide that actually you keep taking or stop feeding them because they're aspirating in and they're getting thinner and thinner, and as they get thinner, they're getting more distressed and their spasms are worse. It is not pragmatically possible to sensibly implement continuing artificial nutrition hydration in that situation. So despite the patient's wishes, it can't be done. And then the final thing is authenticity. So the strength and consistency of the views being expressed by the patient or by their family. So is there a consistency? They say they're Catholic. Did they go to church? So where I'm heading towards with this is that capacity is insufficient for autonomy. And autonomy not only involves capacity, but it involves the ability to be able to make a choice. And there are some people who have intellectual capacity, but nonetheless are not able to make a choice. So, here's a patient. They're 60 years old, they're high achieving, there is no doubt about their intellect, they're an elite amateur athlete, and they've had a C6, C7 complete cord lesion and a tetraplegic. In the long term, this patient wants to be able to sit out for 6 hours a day so he can get out into the community and watch sporting activities, and in particular his son playing rugby. At the moment, he's dependent for all bed mobility. Turning is painful for him, and he refuses. So what's the right thing to do in this situation? And the reason I picked this as a story is because this is a patient who is cognitively intact, there is nothing above the neck, and because it's urgent. You have to make a decision today because by tomorrow morning they could have a grade 4 pressure sore. So, who's going to refuse to turn him? He hasn't given consent. Oh, I'm so glad. Okay, who's going to refuse to answer the question on the grounds that they don't want to commit themselves? Hands up. Let's start there. So you're all going to give me an answer when I ask. Okay, who's going to go for option A? No one. Okay, who's going to go for option B?
More than one.
No. Okay, you would. Okay. Who's going to go for option B? Okay. Who's going to go for option C? Okay. Who's going to go for option D? Okay. And lots of people haven't answered. And of course, if you go for option D and he complains, you could find yourself in front of a disciplinary the following morning. So if you're interested in option A, you're really focusing on autonomy, or certainly on capacity. If you're looking at option B, you're thinking about non-maleficence. If you're thinking about option C, you're probably focusing on equity. And if you think about option D, you're thinking about beneficence. So, is this patient autonomous? We've pretty much agreed he's got capacity in that there's no problem above the neck. So to be rational and therefore simply unwise, his decision must be authentic. So an example of that is it is completely rational to refuse blood products if you are a Jehovah's Witness. Many people would think you are unwise, but it's rational. So we can assess whether or not he is rational or unwise by looking at, in legal terms, the strength and consistency of the views expressed by the patient. In philosophical terms, you might say whether the decisions and desires make a coherent set, and we would say whether their actions are in line with their identity and values. And one of the things that makes us human beings is that we seem to be able to plan things and to look at sequences of events. So the philosophers talk about first-order desires. So either I want to turn or I don't want to turn. But then there are second-order desires, such as I want to be able to sit out in my wheelchair for 6 hours. And what we would think of as autonomy would then be when your first-order desires and your second-order desires match, when there's an identification between them. And the reason why that's important is because that's the area where we think about free will, where we start to think about agency. So if his first-order desires are not in line with his second-order desires, then he doesn't have agency. And we might have some view that actually this is not an unwise decision, this is an irrational decision. So We can think about practices, habits, or even short-term goals. We can think about principles, perhaps long-term goals, or just this is how I think we should do things, values and identity. So an example which would be very easy to relate to would be, I read to my kids every night. I do things. Why do I do that? Because the principle is I do things with my children they enjoy. The value would be a good family life, and the identity would be I am a good parent. So in this case, the identity is I'm interested in sport. The value are we are an active family. The principle is I'm working towards improving my sitting balance at all possible occasions. And the habit would be I turn when I need to. And we can't see that linear relationship in this patient. So we might say, okay, his views aren't intelligible, they're not rational. So then the question comes, oh, go on, Will.
In that just example that you gave,
Mm-hmm.
the first bit was I turn when I need to.
Yes, okay.
So he might argue that,
You can't.
no, I think he could argue I'll turn when I want to. But I'm going to him on my time and saying, right, it's time for me to turn you.
Yeah, and that is an
That's
issue.
the only difference in that take.
Yeah, okay.
Sorry.
I'll change the slide. Next time I give this talk, I'll change the slide. Right, so if he's not, in this sense, rational, yeah, the question then is, if not, why not? And there are two possible reasons for thinking about this. One is emotional distress, and the other one is the way he now experiences his body. So in terms of emotional distress, this has been addressed in the Court of Protection, I'm sure, on many occasions. But here's an example of a patient with an emotionally unstable personality disorder who has very difficult to control diabetes, and her management is becoming more and more difficult. And people have gone to the court to ask whether or not essentially they can force treatment on her. And in the judgment, there's a couple of things that are quite interesting. So the first one is decisions to refuse care appear not to be driven by a process of using and weighing information, but by impulse, with a deep-seated wish to take control of her life. Essentially, it's an impulsive and emotionally driven response. Now, we might argue that this man, who has just had a catastrophic injury, is emotionally driven. He has no control. And so if he's had a bad day, something hasn't gone very well in the gym, or a doctor's been to see him and told him something he doesn't want to hear, in an attempt to take back control, and because of the level of distress he experiences, he may just metaphorically dig his heels in. The second thing I thought was interesting in this judgment is her state of mind and ability to make decisions are also affected by fluctuations in her blood glucose. There are times when she might be able to make a capacitous decision about care and treatment, but other times when she can't. So if this patient has pain when he's turned, and if his pain is particularly severe that day, then he will focus on that and be incapable of making a decision. So I think one could argue that in some situations we have patients who are capacitous, but apparently irrational. It's a difficult word, that, because it's not that irrational. But they are so distressed they cannot make a decision. The other reason why people might not be able to make a decision is because of these concepts of physical embodiment and agency. So in the normal course of events, we have an idea of a narrative through our lives. We can make sense of our lives in a single narrative. If you have, say, a brain injury, there is a discontinuity, and that's particularly severe if you've had a period of amnesia. And there is the you before the injury and the you after. And as rehab professionals, what we try and do is knit those two bits of identity together, normally by an appeal to someone's values. But for this man, it's really difficult because he is going to be wheelchair dependent and dependent on someone else for all physical aspects of his life from now on. So there's this enormous discontinuity. And in that space, while you're doing that work, we're asking him to be rational. And one of the things, I think this is an excellent paper because it talks about re-envisioning autonomy, but it talks about embodied capacities. So it says human agency, and it's really interested particularly in human agency. And they went on and wrote another paper, and this paper was about a patient who was a 40-year-old mechanical engineer, physically active, played tennis, swam, ran, and belonged to a number of social clubs where the sport was the key element of it. So her social life was bound up with this idea. And in the story they tell, for 4 months she has developed pain, she has developed fatigue, her sleep has not been refreshing, and her pain is not responding to analgesics. And after the necessary runaround between neurologists and rheumatologists, eventually a diagnosis of fibromyalgia is made. And she goes to see her GP, who says, well, we've got a couple of things we could do here, but you're going to have to do much less exercise. You're going to have to give it up. This is someone else's case history, Gita. And they go on and say, if Mairead had there and then chosen one of the sets of therapies recommended to her by her GP, then given that a substantial part of her practical identity is bound up with her way of life as an amateur athlete, and there was no option for pursuing a treatment that would re-establish that practical identity, the authenticity of that choice would be cast into doubt. Of course, Mairead might have decided on a set of therapies that best allowed her to live a way of life as a mechanical engineer, extrovert, and so on, but she couldn't do that. And so it is not the case that such a treatment decision would have been necessarily inauthentic and non-autonomous. Nonetheless, despite having the necessary cognitive capacity for autonomy, she is unable to make a treatment decision. So she's cognitively capable, she can make choices that restore other parts of her identity, but when she's asked by her GP, which do you want, she says, I don't know, I can't decide, you need to give me time. And even when he pressurises her and says, but the sooner we get you started on treatment, the better, she says, I don't know, I need time. She can't do it. And that may be exactly the same as with the patient I was talking about before, but we don't have time. And in the conclusion, they say, we've argued that when a patient experiences bodily disunity and expresses themselves in ways in which a clinician judges to be indicative of irrationality and or a lack of autonomy, or when a patient will never again be able to embody the practical identity they had before the onset of the present condition, the autonomy of their treatment choice can substantively depend on their bodily capacities and expressions and the ways these relate to the patient's mental capacity and cognitive processes. And at one level, we accept this because we talk about patient activation. We talk about the fact that if you have a chronic disease, that you have to work with someone over a period of time to move them from that overwhelmed period to the point at which they can self-manage. And the guidance around patient activation says meet with the patient weekly for the first couple of months, then monthly, then every 3 months. And eventually you move them along. But with this patient, we don't have time. So, what's the right thing to do? Who is going to refuse to turn him? He hasn't provided consent. Who is going to turn him? It's going to stop him getting a pressure sore? Good. Okay. Who's going to try and persuade him but give up after 45 minutes? Yeah, and who's going to turn him? It's congruent with his long-term goal and his best interests. Yeah. So we'll perhaps talk about how to do that at the end. So this is another patient. This is a much greyer, I think, a much greyer problem. So another professionally high-achieving individual, elite athlete, and they've sustained a middle cerebral artery territory stroke. She was still working, very active. She's significantly disabled. She transfers with a return and assist of 1, has occasional fecal incontinence. She insists she will go home. I don't need care. My husband will do it for me. It'll be fine. And she's deemed to have capacity. And Mr. B appears willing to look after her, but he's about 5'0". He's got rheumatoid disease, he looks frail, and he can just about manage to transfer her with a return, but it's a bit of an effort. You know, gives the therapist the screaming hab-dabs, but he can do it. Do we accept that at face value? Do we say that's okay? Do we say, well, it's a marriage, you don't know what happens in a marriage, it's for better, for worse? Do we say, her attitude is a disgrace, how dare she rely on him? Do we say, his attitude is a disgrace, why has she been earning for him for 20 years? Do we say, which is most likely, get out of my bed? Or even better these days, with discharge to assess, do we kick it into the long grass and hope someone else will deal with it? All these things are possible. But Chris Ward wrote about patient-centred care, suggesting it perhaps wasn't a good thing. So Chris was a neurologist who did rehabilitation medicine, was Professor of Neurological Rehab in Nottingham, and he retired to become a systemic family therapist. And he talked a lot about the way we as clinicians interact on the patient system. And he said, if the physical environment can both produce and alleviate disability, so too can the social environment. And we are part of the patient's social environment. And if we take a sort of very conventional approach, we would say the clinician deals with the patient and the problem they present with. But in doing that, we start to enter the dynamic. And he would give stories of usually women with MS who would come to clinic with their husbands, and the husbands would want to know, is there anything I can do? They'd want to fix it. And doctors like fixing things too. So the next thing that happened was the kit would start to arrive in the house. But if the woman has an identity of a homemaker, if she spent a long time making her house nice, what the doctor has done inadvertently is drive a wedge between husband and wife, which, given we see them for what, an hour a year, is a bit of a cheek, really, because their greatest source of support is in each other. And our job ought to be to try and make sure they stay on the same page. And so we need to take a systems look at this, and this is back really to the feminist and relational ethics. What is going on here? And we are all part of this problem. So what is the support network and how do we look at it? And it could be that in this situation, Mr. B is coercively controlling Mrs. B. He's sent her out to work, he's made her work too hard, she's now had a stroke. It could be Mrs. B is coercive, she goes off swanning round the world, and he stayed at home and done all the cooking and cleaning. We don't know. But we don't understand the nature of their autonomy until we understand the dynamic. So, a person is autonomous when they have the power and authority to direct affairs of importance in their life within a framework of rules that they've set for themselves. Identity can be defined in dialogue with and sometimes in struggle against the people around us. And oppressive socialisation, oppressive practices, whether they come from doctors or anyone else, can diminish autonomy and perhaps undermine it altogether. So what I want to think about is how do we move from this concept of capacity, because these patients would be capacitous, to one of autonomy, which allows us to get the best outcomes for our patients. So originally I said, to put most simply, to be autonomous is to govern oneself. Failure to make such decisions can be related to physical and emotional stress and distress. Bodily intentionality, the ability to move skillfully through the world, to have agency. When most of us make a decision, we follow it up with an action, is an important part of autonomy. And so we need to make sure that our patients start to feel comfortable in their new bodies as much as we can. And relational factors may support or hinder the expression of an authentic decision. So autonomy probably is a sense of wholeness that is consistent with authentic traits, affects, values, and desires, and is enacted by skillfully, physically, and cognitively engaging and responding to the environment through agency. And if we think of autonomy in those terms and stop worrying so much about capacity, patient A was not autonomous. And therefore our judgments about what is right to do need to be taken within that context. Now, as I say, these things turn up at 10 o'clock at night. They often turn up for the nurses and not for us. I don't know, how many nurses are here? Okay. And it's easy to be critical of what happens. But I think we need to be very clear about what we do when we meet these sorts of problems. So when the ethics are complex, write it down. Write down the problem, write down the environmental factors, lay out the clinical reasoning, and if you do something out of beneficence, people might say to you, well, I wouldn't have done that, but it's quite difficult to argue with. And if you do that, you can then take it to a clinical ethics committee. And all hospitals have clinical ethics committees. The UK Clinical Ethics Network exists for us to take patients to, and on their website there are a series of useful documents which talk about how to lay out ethical problems. So this one is called the 4 quadrants approach, and essentially you look at the indications for medical interventions, you look at the diagnosis, what are the options for treatment, you look at the quality of life issues, you look at the preferences of the patient and the contextual factors. This one comes from the Oxford Ethics units, and they take out this 11 structured questions. But what is interesting is they say, identify the options and the morally significant elements, pick one, work that one through, say, are there any counter-arguments to the options you've chosen? Can you rebut the argument? And then make a decision, and then importantly review it. The final approach they suggest is the ABC toolbox, where you start by analysing the facts and values. You look at your principles and intuitions, and different people have different intuitions because they instinctively work towards one of the different philosophical frameworks. And then compare cases. Think about other cases that have been like this and how they worked out and the decisions that were made. And if you like, it's that comparing of cases that quite often goes on in the court of protection. So in conclusion, I would say there's an abundance of clinical guidance. The legal frameworks are clear, but ethical problems can still arise when the 4 principles conflict. The concept of autonomy is rich and it's multifaceted, and it may not map easily onto the legal concept of capacity. And if the answer still seems unclear, lay out your concerns and reasoning formally and go to a clinical ethics committee. Remember safeguarding. We all remember safeguarding. And if a patient lacks capacity, a best interest decision is contested or finely balanced and it's significant, you have to think about the court of protection. So the last word will go to Beecham and Childress. Not only do we hold the principle of respect for autonomy lacks priority over the other principles, we maintain it is not excessively individualistic to the neglect of the social nature of individuals, nor excessively focused on reason to the neglect of the emotions, and not unduly legalistic by highlighting legal rights while downplaying social practices. Questions?
Any questions, people? I have a question whilst people are thinking about things, or maybe it's just a thought really, because we pay a lot of time in the concept of capacity in our decision making. So I don't know how many times we hear each other say, "Oh, but they have capacity, so that's fine. They've made that decision." Now, obviously, you presented some good examples of that today about where you may find yourself overriding that. I had an interesting patient today who we were considering whether she had capacity or not because she was making a funny decision. However, if she didn't have capacity, she had an LPA in place. And the LPA... The sister who had the LPA was the person driving the funny decision.
Whoa. That's what the Court of Protection's for.
So it was a really difficult interaction, and I just wonder your thoughts on it, yeah.
Well, I mean, the terms of the LPA are very clear. The attorney has to operate in someone's best interests. So again, it is about the consistency in the evidence, I think, that the decision is rational or unwise. But if there is some evidence that this is not what the patient would have chosen for themselves, if the rationality of it can't be explained, then actually you have to start to ask questions about the attorney. Attorneys have to operate in the best interests of the patient, and if not, you go to the Court of Protection. Or you kick it into the long grass. Make sure everything's done ethically within reason, yes.
Thank you, Diane. I enjoyed that case that you put up, mainly because we've had that on the ward in the last 6 months. And it's been really difficult. The only bit that I would be interested in your thoughts on that but wasn't there was if you don't go with that autonomous choice at the top, and the patient said, I don't want to be turned, but you're going to do it anyway, the impact that then has on the relationship between the patient and the team. And if that starts to break down, do you lose any ability to then actually do things in their best interest or for the good of that patient?
No, and I think that's a really good point, Will. I mean, I think in turning someone who doesn't want to be turned, you're probably assaulting their autonomy, and that's a risk. I think one of the things to think...
would say you'd be assaulting them physically.
Yes, but I think there were a couple of things I thought about when I was working this one through. One is, I think that it ought to be possible to have a conversation at a time when he is less distressed, in which you essentially get an overarching consent that even when he doesn't want it doing, actually you're going to go ahead and do it. Because people fluctuate, and they fluctuate because you've had a bad day. So I think there is something about having that conversation and laying it on the table. The other thing that struck me about it when I looked at it was I thought, well, actually, if the issue is really severe pain at the point of turning, are there other solutions? Now, obviously, people do everything they can. You know, hydrodilatation, nerve blocks, all the rest of it. But actually, the thing I wondered about was gas and air. We don't get gas and air up on the ward to turn people. And actually, if someone's that distressed by the act of turning, maybe one should. So again, I think there's probably something about thinking out of the box a little bit about it. And certainly in the first instance, if someone doesn't want to be turned because they're in pain, on that occasion, give them a decent dose of diamorph, then turn them, then have the conversation the following day. But I don't know. They're knotty problems, and that's why I picked this particular problem, because it is an above, it's both simple and really complicated. There are no right answers, and I'm certainly not pretending to have them.
We have a question in the middle here.
Hi there. So it's kind of following on from Susan's question, actually, because I'm in a very similar situation where we've got a problem with a patient who we feel doesn't have capacity, and her LPA is not acting in her best decision. She's acting in a decision about money. So it's about discharge to a care home and who's going to pay for it, and not wanting to pay for it. And so the idea of quarter protection hasn't really been explored or discussed. Social services are involved. And I just wondered, practically, how often do the Court of Protection get involved? And how easy is the process?
I don't think the process is terribly easy, and I suspect by the time you actually get to the Court of Protection, there may have been a solution in place for some months. But I mean, I guess the first route is via safeguarding, isn't it? And it's for safeguarding perhaps to decide whether or not this is something that they want to take to the Court of Protection. But again, it's difficult, and the Court of Protection is not easy to access, and it's expensive. I think it costs about £25,000 every time you take a case to the Court of Protection.
I think there's a question over here first, and then...
Hi there. Yeah, hi there. I was just thinking about the consequences. So they're different, right? In case A, or the picture you painted was if you didn't turn him, he'd end up with a pressure sore, possibly life-threatening, or something that would cause distress for weeks or months, possibly the rest of his life. Whereas turning him against his will, as you say, he can come back again tomorrow. So I think that was part of the thing that was pushing me towards D. I think if it was equal, if it was just not turning him just caused pain and no long-term disability, I think then maybe you can't.
Yeah.
So isn't it a bit about the consequences?
I think it is about the consequences, and I think it is about, they are really significant consequences, and that's why I think if you see something where the consequences are as significant as that, laying out the reasoning, people might say, I don't know if I agree with you, but I think it would be very difficult for someone to say, actually, you did something wrong. Because there are no right answers here. There is simply a judgment call in the moment.
As a comment stroke question, I think in rehab we spend a lot of time, our duty or our interaction is not just with the patient, of course, but we spend a lot of time with the family and with all the other carers. And I find it hard, I think hopefully we all do, that our considerations aren't necessarily just directed towards the patient. Actually, we find ourselves treating the whole family. And there's a sort of slippage as to where our ethical responsibilities lie if we're just considering the patient or if we're considering the wider group that they sit in, the social milieu that you refer to. And it can be quite difficult to distinguish between the two and to keep focused on the patient. And I think there's some examples where there's a clear conflict of a specific decision, whether, for example, the recent one we've had about giving somebody antipsychotic medication who becomes agitated in order to prevent the situation breaking down once he gets home. Family object. We think it's in his best interest. It'll break down. He'll end up in a nursing home, but they disagree. So that's sort of a straightforward conflict in a way. But then it gets more difficult in a situation like a PDOC patient, for example, vegetative state. Family want you to do everything. You think that it's not in their interest, and they don't have a quality of life. So you're thinking, are you actually treating? If you continue CANH, are you treating the family? Because of course they're the ones who want to feel they've done everything. They don't want to be left with the feeling they didn't do everything they could. Or you're treating the patient. But of course, once the patient eventually passes away, the family are the ones who've got to then continue and live with it. And in a sense, maybe the ethical thing is to treat the family in that situation and let them feel like they've done the right thing. Do you see what I mean? So there's situations where your responsibility to the patient versus your responsibility to the wider social network they sit in can be in conflict. And I don't see, the law doesn't really acknowledge that. But I think we all find ourselves in that grey zone, or at least I do.
Well, I think in general terms, I would take the view that it is rarely in the patient's best interest for the medical team to be at loggerheads with the family. And the other thing is, I would go back to that patient activation approach. When someone is in a vegetative state or a prolonged disorder of consciousness, the family are overwhelmed and unable to make a decision. And we try and push that decision-making process, certainly in the NHS, into a 3-month window. But if it was any other chronic condition, we would accept it takes 18 months. And so actually, I think the difficulty is that we try and push that decision-making very tightly, and then we get at loggerheads with the family, and then they dig their heels in. And so I think that unless the patient is overtly distressed, unless they're overtly storming, they're having repeated infections, and then actually there are often quite a lot of opportunities to let someone die by some means other than withdrawing clinically assisted nutrition and hydration, quite often. Actually, we just don't have the resource, and we need the resource to make these gentle conversations over a long period of time, and little and often instead of big bang. And we just don't have the resource to do that. And so there's this feeling we have to get it done before they go to a nursing home.
So I've had an interest in how we look at culture and the definitions of culture, the individual, the institutions, society, and how that impacts us in healthcare. And there is a thinking that autonomy is a very Western concept, culture, from a cultural perspective. And actually, we can think of times where sometimes what we've thought has been the best for a person, actually talking about the family and the sort of the community and etc. may not necessarily be so. You've obviously done a huge amount of reading in this area. I haven't, but how have they addressed that? How actually this, some of that model, the framework, and actually could be coming from quite a Western standpoint, and what that means when we are in diverse communities and diverse cities, etc. And actually has this sort of idea of medical ethics also been explored from another standpoint?
Yeah. So it is a concern, but if we go back to the United Nations Declaration of Human Rights, there was always a lot of discussion about whether or not that was Western focused. But actually very few countries at the time from the United Nations refused to sign it. And the ones that did were either for religious reasons, so Saudi Arabia refused to sign it because they said that some of what was being put in it was inconsistent with Islamic beliefs. And in fact, the Russians refused to sign it because they had a different concept of community. But actually, the majority of countries did. And so I think one has to be careful about imposing views. But I think actually within those 4 pillars, although the weight given to each pillar might change, they are still valuable pillars. But yes, I think often what we see is a clash of cultures. I mean, at the simplest level, when a family come onto a rehab unit, it encounters the rehab unit's culture. And often that's where the conflict arises, which is, I think, one of Chris Ward's sort of points. We have to take a systems view about what's going on.
Any other questions? If not, we might wrap it. Was there a question up there?
Yeah.
I thought I'd seen someone's hand go up there before, but I couldn't identify it.
Just coming back to the example of the patient refusing turning, we have somebody similar, but he has a spinal cord injury and is a paraplegic, and it's around the bowel care situation. And again, he has in the legal terms, capacity, but again, his autonomy would be questionable because, yes, he is really low in mood and struggling to come to grips with his bodily changes. But in that scenario, the option of just implementing the bowel regime doesn't offer themselves because he's a paraplegic and he's much more mobile. He would fight you off physically, you know, so that option doesn't even exist, acting in his best interest and forcing the bowel care regime upon him. Although, again, you could argue he's making this decision, lacking autonomy to make this decision and ultimately harming himself, which is not keeping, you know. But so you have the same dilemma, but you haven't any practical ways of addressing it.
And that's really hard, isn't it? Because that's probably the definition of a tragedy, because there is an inevitable end to that, which is terrible. And it's created by a situation and a personality. Sort of Shakespearean, really.
Well, we might wrap things up there, but thank you so much for all of your questions. Diane, it has been one of the privileges of my career to work with you, and I think people here tonight will have seen part of the reason for that. The level of discussion and challenging of concepts just in daily practice has always just been incredible, and it's lovely to see that tonight. Thank you.
Thank you.